Um, Hello, everybody, and nice to meet you again. My name is Ahmed Youssef. I am one of the ENT head and neck surgeons, and my topic today will be discussing the targeted therapy in head and neck cancer. As we all know, we face all this kind of patients as being presented with either irresectable disease, either mucosal squamous cell cancer, locally advanced unresectable hypopharyngeal, esophageal, or advanced squamous cell cancer of the larynx that is being unresectable, explained by the fact it's been engulfing the carotid or going to the prevertebral space or going down, where an actually patient with a recurrent disease following chemoradiation has been tracheostomized, and this disease is a really recurrent and aggressive. And again, surgery is not the magic line of treatment for patients with an advanced skin cancer that by mainly SCC or some PCC that can be not amenable for any kind of a local treatment. Alone, local treatment wouldn't be enough, explained with the fact this is invading the bone or going to the dura. This is again a very, very locally advanced disease. So surgery alone is not the main line of treatment. How about other weapons as well, like radiation and chemo? They has been very well utilized and very well described in treatment of squamous cell carcinoma, specifically of the head and neck cancer, by acting on certain kinds of the cell phase, like we will mention about the cell cycle in a second. However, because they are not working only on the squamous cancer cells, there will be other side effects related to their action on rapidly proliferating cells like bone marrow or hair or even the gastrointestinal tract or the mucosa of the oral cavity and oropharynx. This is all the side effects of radiation and chemo that leads to a severe toxicity that might affect the patient's life more than the cancer itself. So there must be a solution for this kind of presented cancers, squamous cell cancers, and the solution here will be a sort of targeted therapy. Targeted therapy is a therapy that it is a kind of medication that it is working specifically and targetedly on the cancer cells rather than the normal cells. And because of that, it can spare the side effects of the chemotherapy or radiotherapy by working on all the cells rather than the only cancer cells. When we are describing this, then we have to go back to what is called the cell cycle to understand how radiation and how the cells is behaving and how radiation and chemo can behave and how targeted therapy can behave. So the cell cycle has four phases, starting with the G1 phase. Some cells will be in G0 phase, like neural cells that never proliferate when it started to grow. Like G1 phase is all other cells and the replaced cells like an epithelial squamous cancer, the squamous epithelium of the skin or the mucosa that's usually proliferating and being replaced. They start with the G1 phase, which will be preparation of the DNA, and following by an S phase, which is the synthesis of the DNA, followed by the G2 phase, which is the second checkpoint in which the cells are arranging the DNA, getting rid of all the bad DNA or bad mutations or bad cells to go for the mitotic phase through which the mitosis can happen and the cells can proliferate. So why the cancers are not produced? Usually because like the cells are always in following these phases, or for any certain reason, the G1 phase has been so much activated by the oncogens or oncogenesis, or the G2 phase, which is usually the second checkpoint managed by tumor suppressor genes like P53 or P16. If it's already lost, then the second checkpoint, which is responsible for to control the behavior of the proliferating cells, if these two checkpoints in G1 and G2 has been for a certain reason deranged, then that will lead to progression into a cancer. And how the chemotherapy is working, it's working in the S phase by preventing the DNA synthesis by alkylating agents like microtubule inhibitor like cisplatinum or 5-fluorouracil, working on the DNA synthesis. The G2 phase is the action of the DNA break repair, which can be deranged by the radiotherapy. So if we have a badly behaving cells, by working on the G2 phase artificially by radiation, this will kill all the DNA, and this is again resulting to side effects as well in the normal cell compared to the cancer cell or with the cancer cell as well. So the DNA break that can happen in G2 phase that preventing to formation of a normal proliferating cells, that's a side effect of radiation, or that's the effect of radiation on the cancer cells. Targeted therapy will work either on the S or G2 phase in the way that prevents it's only on the receptors or into targeting the cells that is suppressing certain factors in cancer cells compared to the normal cells. And that's the way that the cancer cell will show the squamous cell cancer. Anti-metabolites or microtubule inhibitors of the nucleus, all this can happen in normal cells and abnormal cells. However, in abnormal squamous cells, there will be an expression of what is called certain receptors, which is an epidermal growth factor receptors. If it's been activated, that will lead to an intracellular cascade and activation of other intracellular enzymes like tyrosine kinase or MEK receptors or MEK enzymes or BRAF enzymes. These enzymes, intracellular cascade, will work on the nucleus to get into DNA proliferation and DNA growth and cellular growth and proliferation. These cells also can be attacked by the immune system if it's been identified, and through which there will be activation of metalloproteinases by macrophages. This will lead to engulfment of these abnormal cancer cells by the immune system. However, the cancer cells usually is very small to escape that identification of abnormal cells by the T lymphocytes, as we mentioned in a second, by expressing certain agents on the receptors that prevent them from being identified by the T lymphocytes or the normal immune system. All this will sit down in an environment where they can have the oxygen and the nutrients by certain vessels. If we work on the vessels itself, by the angiogenesis factors, by doing an angiogenesis inhibitors in certain agents that can deprive the cells from oxygen and the nutrients and prevent the progression into cancers. So, in short, the targeted therapy either we target the receptors of the cells by immune-mediated receptors or immune-mediated treatment called an immunotherapy, targeting the epidermal growth factor receptors on the top, or the vascular endothelial growth factors on the top, or insulin growth factor receptors on the top as well, or by activating the immune system to attack the cancer cells, which is called non-receptor targeted BDL1 or 2 inhibitors that we will mention in a second, or by targeting the intracellular cascade enzymes, tyrosine kinase inhibitors, or the MEK or BRAF inhibitors. This is all attacking the intracellular cascade, leading to decrease in tumor growth and progression. Epidermal growth factor receptor inhibitors. We targeted the epidermal growth factors in the surface of the squamous cancer cells, and it's well expressed in 90% of the squamous cancers. By activation of this, by giving a monoclonal antibodies targeting these receptors, that will lead to, first of all, these receptors will not function, resulting into decreased tumor growth and proliferation and DNA activation. And again, that will lead to, identification of these cells as an abnormal cells because there will be an antigen-antibody reaction on the surface of the squamous cells and can be facilitate engulfment by the identification by the lymphocytes and macrophages. So that will lead to an apoptosis, which is a programmed cell death. One of the most common factors in most common agents that has been tried in the literature many years ago, epidermal growth factor receptor inhibitors or monoclonal antibodies against the epidermal growth factor, anti-epidermal growth factor receptors, which is called cetuximab, and that's a mechanism of its action. Inhibit cell proliferation, impair DNA damage repair, alternate tumor progression, promote apoptosis. And it will help as well with the DNA induced, inhibit the radiation induced, because usually in radiation, the cells that can escape radiation effect by rapidly proliferating by doing, and the rapid proliferation can happen if there is any epidermal growth factor receptor on top. By getting these agents that again will damage or affect the expression of epidermal growth factor receptors on the cells that can recover from the effect of radiation. That's how the cetuximab working by antibodies against the epidermal growth factor receptors. It can be given as 40 milligram per meter square. That can be maintained as an initial dose, 250 gram per meter square weekly. It has some side effects as any immune-mediated medication that can result into acneiform rash or some lung or hypersensitivity or some interstitial lung disease. It's prohibited in pregnancy as well. However, it's most of the patients is being tolerated. It's been tried compared to use of as a gain compared to only the radiation, and showed that if it's being used with radiation, it has superior tumor control compared to the radiation alone, which means that it's effective. And we compared with the de-escalate trial, comparing the cisplatin, which is one of the chemotherapy agents, with radiation compared to the cetuximab with the radiation. And we expected that the side effects from the cetuximab with radiation would be less. However, the toxicity from the radiation was the same. Either we use a cisplatin or cetuximab. However, there was a bad outcome regarding the tumor control by using the cetuximab alone, because the cisplatin showed a superior tumor control when it have been used with radiation compared to use of cetuximab with radiation, which means that the cetuximab is not enough for tumor control. And has been tried in the de-escalate trial in P16 positive SCC low risk patients. So again, cisplatin is favorably used with radiation as a chemoradiotherapy treatment of HPV positive SCC. However, if the patient cannot tolerate cisplatin, or the side effect of cisplatin, like kidney disease or having bad kidney disease, then cetuximab can be used at this point. Insulin-like growth factor receptor blockers has been tried before, but not very well documented. It has any significant activity in treatment of head and neck squamous cell carcinoma. Anti-angiogenesis factor, we talked about the cells, if you need to be growing and proliferating, you need the oxygen and the nutrient. By working on another arm, which is angiogenesis, that will deprive the cancer cells from having oxygen and the nutrients. And this is why we are using a vascular endothelial growth factor receptors inhibitors or antibodies, monoclonal antibodies against the vascular growth factor receptors. And can be this agent's named as a bevacizumab. It's not popular in head and neck cancer. It's actually very popular in benign tumors, bevacizumab, like HHT. This is all the trials related to this head and neck squamous cell carcinoma, not very popular and very showing promising results. It has been showing great results in HHT, hereditary hemorrhagic telangiectasia, which is a vascular tumor with angiogenesis, or even like for certain like benign tumors like recurrent respiratory papillomatosis in kids, or an NF2 neurofibromatosis 2, in which there is a bilateral vestibular schwannoma. And by this is all benign things, and by reducing the rate of growth and angiogenesis, that will lead to more control of the disease. Talking about pembrolizumab, you remember now all cetuximab, pembrolizumab, and bevacizumab is all MAP. A MAP, which means that it's an antibodies. It's a targeted therapy, ends by MAP. It's usually an immunotherapy. However, if it ends by EAP, like imitinib or vimrofinib or dabrafenib, which all EAP, it means that it's targeted non-immune therapy like tyrosine kinase inhibitors and PRAF inhibitors as well. So the pembrolizumab is working by an indirect immune way. It's a sort of immunotherapy, targeted therapy, but it is not direct on the receptors. So usually the cancer cells should be identified by the lymphocytes as an abnormal cell. But because the cancer cells are really smart, they expressed what is called on the surface, what is called um, a BDL1. So how the cancer cells will be identified as an abnormal cells? There will be a receptors on the T lymphocytes called BD1 receptors. These called program death receptors. And because of that, they will attack the cancer cells by having this receptor attached to the tumor cells and causing what is called an apoptosis or program death. But the cancer cells are really smart. They express what is called a BDL1 or 2, which is two kind of receptors on the surface of the cancer cells that camouflage the identification of BDL1, or BD1 receptors on the surface of T lymphocytes. By camouflaging this, that will prevent the tumor cells from being identified as an abnormal cell to the T lymphocytes. This is all expressed in most of the squamous cell cancers. We have to test the tumor first for BDL1 or 2 before considering that kind of treatment I will mention in a minute. And if we can do something just to work on these lesions or these receptors, then again, that will help these cells to be identified as an abnormal cells so that the lymphocytes so can attack them. And this is the action of BDL1 or 2 inhibitors or monoclonal antibodies. Again, it's an immunotherapy, targeted therapy antibodies working on the lesions 1 or 2 and be working on this. This will be facilitate the tumor identification by the T lymphocytes or BD receptors, and leading it to apoptosis and program this. This is called pembrolizumab or Keytruda, and has been very well tested in head and neck cancer, either squamous or actually cutaneous skin cancer, especially if the tumor showed BDL1 or 2 receptors. Keytruda can be used as a pembrolizumab, as a BDL1 or 2 inhibitors, especially if the tumor, when we send for pathology, being tested for BDL1 or 2, usually expressed highly proliferative, locally advanced or metastatic squamous cell carcinoma. And then we can prescribe pembrolizumab to start with either over 3 weeks as a 200 or 600 over or 400 over 6 weeks, and has been tried for 2 years. You can stop it earlier if there is a side effects of this pembrolizumab or the patient has a progression of the disease, which means that it's not responsive to pembrolizumab. Keytruda is indicated for a patient with unresectable or metastatic squamous cell carcinoma and the melanoma as well, and it's been indicated for treatment of adult and pediatric more than 12-year-old stage 2B C3 melanoma. So it's not even for squamous cell carcinoma alone, it's again for other cancers as well, like other cutaneous skin cancers like melanoma as well. Drawbacks, because it's an immune-mediated reaction, it can affect other areas of the body, unfortunately, but not every patient. That can lead to an immune-mediated reaction in the kidneys or in the GIT or in the lung. And because of that, there might be the point that we have to stop it. But it's not expressed in every patient. Other targeted agents as well, we talked about NEEP, which is tyrosine kinase inhibitors, working on intracellular domain about tyrosine kinase enzyme, or PRAF or MEK enzymes as well as an inhibitors. By working on the tyrosine kinase receptors that prevent the intracellular cascade resulting into DNA proliferation and mitosis. Tyrosine kinase inhibitors has been tried in squamous cell cancer, but showed very good results actually in thyroid cancer, like medullary or anaplastic thyroid cancer. Performic inhibitors, this is again an intracellular enzymes. By targeting them, they will be a very good control of the disease and prevent further progression into tumor progression and tumor growth. and that has been mainly tried and showed good results into melanoma rather than because there will be high expression of PREF enzyme or having a high rate of PREF mutation by having these PREF inhibitors like dabrafenib or vemurafenib. This is again can work on the intracellular cascade and prevent of the progression into cancer. Has been been experimented and tried in a melanoma and showed very good results. That's it. That's a small um, presentation and resume about the targeted therapy, and that's an important kind of treatment. It's promising trial has been in advanced squamous cell cancer. Now we're talking about it in advanced skin, advanced oral cavity cancer, or it's a very good weapon as a new adjuvant treatment. Nowadays, they tried that compared to the surgery alone. It's another important weapon compared to the chemotherapy. So far, is not enough, but an important tool, especially for a metastatic or a locally advanced disease. You can try it first, or you can try it in combination with other treatment like radiation or surgery, and it can be used in whenever there is no other solutions in cases of metastatic or resectable disease. Thank you very much.